Hello, and welcome to another chapter of Advanced Pharmacology. Today we'll be talking about Chapter 34, the review of hemodynamics. So, the review of hemodynamics. Hemodynamics is the study of movement of blood throughout the circulatory system, along with the regulatory mechanism and driving forces involved. Concepts introduced here reappear throughout the chapters on cardiovascular drugs, so we urge you to review these now. Because this is a pharmacology text and not a physiology text, discussion is limited to hemodynamic factors that have particular relevance to the actions of drugs. So, the overview of the circulatory system. The circulatory system has two primary functions: delivery of oxygen, nutrients, hormones, electrolytes, and other essentials to cells, and the second being removal of carbon dioxide and metabolic wastes from the cells. In addition, the system helps fight infection. The circulatory system has two major divisions: the pulmonary circulation and the systemic circulation. The pulmonary circulation delivers blood to the lungs. The systemic circulation delivers blood to all the other organs and tissues. The systemic circulation is also known as the greater circulation or peripheral circulation. So we do have some components of the circulatory system. The circulatory system is composed of the heart and blood vessels. The heart is the pump, and that moves blood through the arterial tree. The blood vessels have several functions. So we'll start with arteries. Arteries transport blood under high pressure to tissues. The arterioles are the control valves that regulate local blood flow. Capillaries are the sites for exchange of fluid, oxygen, carbon dioxide, nutrients, hormones, and waste. Venules collect blood from the capillaries. Veins transport blood back to the heart. In addition, veins serve as a major reservoir for blood. Arteries and veins differ with respect to distensibility or elasticity. Arteries are very muscular and hence do not readily stretch. As a result, large increases in arterial pressure causes only small increases in the arterial diameter. Veins are much less muscular and hence are 6 to 10 times more distensible. As a result, small increases in venous pressure causes large increases in vessel diameter, which produce a large increase in venous volume. So the distribution of blood. The adult circulatory system contains about 5 liters of blood, which is distributed throughout the system. As indicated in figure 34.1, 9% is in the pulmonary circulation, 7% is in the heart, and 84% is in the systemic circulation. Within the systemic circulation, however, the distribution is somewhat uneven. Most, about 64% of the blood, is in the veins, venules, and venous sinuses. The remaining 20% is in the arteries, 13% in the arterioles or capillaries, about 7%. A large volume of blood in the venous system serves as a reservoir. So here you see that kind of distribution of percentages, give or take. So what makes blood flow? Blood moves within the vessels because of the forces that drive flow is greater than the resistance to flow, as shown in figure 34.2. The forces that drives blood flow is the pressure gradient between 2 points in a vessel. Blood will flow from the point where pressure is higher toward the point where the pressure is lower. Resistance to flow is determined by the diameter and the length of the vessel and blood viscosity. From pharmacologic viewpoints, the most important determinant of resistance is vessel diameter. The larger the vessel, the smaller the resistance. Accordingly, when vessels dilate, resistances decline, causing blood flow to increase. When vessels constrict, resistance rises, causing blood flow to decline. To maintain adequate flow when resistances rise, blood pressure must rise as well. So you see that kind of here in this bottom picture. So, how does blood get back to the heart? As indicated in the next picture here, pressure falls progressively as blood moves through the systemic circulation. Pressure is 120 millimeters of mercury when blood enters the aorta, 30 milligrams of mercury when blood enters capillaries, and only 18 milligrams of mercury when blood leaves the capillaries and then drops to a negative value from 0 to negative 5 milligrams of mercury in the right atrium. Negative atrial pressure is generated by expansion of the chest during inspiration. So here you kind of take a look at that. Given that the pressure is only 18 milligrams of mercury when blood leaves capillaries, we must ask, how does blood get back to the heart? In addition to the small pressure head in venules, three mechanisms help ensure venous return. The first being negative pressure in the right atrium, helps suck blood towards the heart. Second, constriction of the smooth muscles in the venous wall increase venous pressure, which helps drive blood toward the heart. Third, and this is the most important one, the combination of venous valves and skeletal muscles contraction constitutes an auxiliary venous pump, as shown in the next figure here at 34.4, the A portion. The veins are equipped with a system of one-way valves. When the skeletal muscle contracts, venous blood is squeezed towards the heart, the only direction the valves will permit. So that's that B portion of this picture. Again, this is a pathophysiology review to some extent, so if I'm going quickly through this, hit pause if you want to review and take a look at all the pictures. So, the regulation of cardiac output. In the average adult, cardiac output is 5 liters per minute. Therefore, every minute the heart pump is equivalent of all the blood in the body. In this section, we consider the major factors that determine how much blood the heart pumps. So, a determinant of cardiac output. The basic equation for cardiac output is cardiac output times the heart rate, or equals the heart rate times the stroke volume, where CO is the cardiac output, HR is the heart rate, and SV is the stroke volume. According to the equation, an increase in your heart rate or in your stroke volume will increase the cardiac output, whereas a decrease in your heart rate or in your stroke volume will therefore decrease your cardiac output. For the average person, a heart rate is about 70 beats per minute, and your stroke volume is about 70 ml. Multiplying these, we get a 4.9 liter per minute, the average value for their cardiac output. So that brings us to our heart rate. Heart rate is controlled primarily by the autonomic nervous system, your ANS. The rate is increased by the sympathetic branch acting through beta-1 adrenergic receptors in the sinoatrial or SA node. Rate is decreased by the parasympathetic branch acting through muscarinic receptors in the SA node. The parasympathetic impulses reach the heart through the vagus nerve. Your stroke volume. Stroke volume is determined largely by three factors: myocardial contractility, cardiac afterload, and cardiac preload. Myocardial contractility is defined as the force with which the ventricles contract. Contractility is determined primarily by the degree of cardiac dilation, which in turn is determined by the amount of venous return. The importance of venous return in regulating contractility and stroke volume is discussed separately later. In addition to regulation by venous return, contractility can be increased by the sympathetic nervous system, acting through beta-1 adrenergic receptors in the myocardium. Your preload. Preload is formally defined as the amount of tension or stretch applied to a muscle before contraction. In the heart, stretch is determined by ventricular filling pressure, that is, the force of venous return. The greater filling pressure is, the more ventricles will stretch. Cardiac preload can be expressed as either an end diastolic volume or end diastolic pressure. As discussed later, an increase in preload will increase your stroke volume, whereas a decrease in preload will reduce your stroke volume. Frequently, the terms preload and force of venous return are used interchangeably, although they are not truly equivalent. Which brings us to the afterload. Afterload is formally defined as the load against which the muscle exerts its force, i.e., the load that the muscle must overcome in order to contract. For the heart, afterload is the arterial pressure that the left ventricle must overcome to eject blood out into the circulatory system. Common sense tells us that if the afterload increases, your stroke volume will decrease. Conversely, if the afterload falls, your stroke volume will rise. Cardiac afterload is determined primarily by the degree of peripheral resistance, which in turn is determined by the constriction and the dilation of the arterioles. That is, when arterioles constrict, peripheral resistances rise, causing AP or afterload to rise as well. Conversely, when arterioles dilate, peripheral resistance falls, causing your afterload to decline. Which brings us to Starling's law of the heart. Starling's law states that the force of ventricular contraction is proportional to muscle fiber length up to a certain point. Accordingly, as fiber length or ventricular diameter increases, there is a corresponding increase in contractile force. Because of this built-in mechanism, when more blood enters the heart, more is pumped out. As a result, a healthy heart is able to precisely match its output with the volume of blood delivered by the veins. That is, when venous return increases, cardiac output increases correspondingly. Conversely, when venous return declines, cardiac output declines to precisely the same extent. Therefore, under normal, non-stressed conditions, your stroke volume is determined by factors that regulate venous return. However, why does contractile force change as a function of fiber length? Recall that the muscle contraction results from the interaction of two proteins, actin and myosin. As the heart stretches in response to increased ventricular filling, actin and myosin are brought into a more optimal alignment with each other, which allows them to interact with greater force. So, there are several factors that determine venous return. Having established that venous return is the primary determinant of stroke volume, we need to understand the factors that determine venous return. With regard again to pharmacology, the most important factor is systemic filling pressure. The normal value for filling pressure is 7 milligrams of mercury. This value can be raised up to 17 milligrams of mercury by constriction of the veins. Filling pressure can also be raised by an increase in blood volume. Conversely, filling pressure and therefore venous return can be lowered by venodilation or by reducing blood volume. Blood volume and venous tone can both be altered with drugs. In addition to systemic filling pressure, three other factors influence venous return. The first being the auxiliary muscle pumps discussed previously, the resistance to flow periphery vessels and the right atrium, and lastly, the right atrial pressure, the elevation of which can impede venous return. None of these factors can be directly influenced with drugs, so keep that in mind. Starling's law and the maintenance of systemic pulmonary balance. Because the myocardium operates in accord with the Starling's law, the right and left ventricle always pump exactly the same amount of blood. When venous return increases, stroke volume of the right ventricle increases, thereby increasing delivery of blood to the pulmonary circulation, which in turn delivers more blood to the left ventricle. This increases filling of the left ventricle, which causes its stroke volume to increase. Because an increase in venous return causes the output of both ventricles to increase, blood flow through the systemic and pulmonary circulation is always in balance, as long as the heart is considered healthy. In the failing heart, Starling's law breaks down. That is, the force of contraction no longer increases in proportion to increased ventricular filling. As a result, blood backs up behind the failing ventricle. In this example, output of the left ventricle is 1% less than the output of the right ventricle, which causes blood to back up into the pulmonary circulation. In only about 20 minutes, this small imbalance between the left and right ventricular output shifts a liter of blood from the systemic circulation to the pulmonary circulation. So, in less than 40 minutes, death from pulmonary congestion could ensue. This example underscores the importance of a systemic pulmonary balance and the critical role of Starling's mechanism in maintaining it. So here you're taking a picture of how that shift could occur in picture form. Again, if I'm ever going quickly, just hit pause. So, the regulation of arterial pressure. Arterial pressure is the driving force that moves blood through the arterial side of the systemic circulation. The general formula for arterial pressure is the arterial pressure equals your peripheral resistance times your cardiac output, where AP is the arterial pressure, PR is the peripheral resistance, and CO once again is your cardiac output. Accordingly, an increase in your PR or cardiac output, so peripheral resistance or cardiac output, will cause an increase in your AP or arterial pressure. Whereas a decrease in your peripheral resistance or cardiac output will decrease your arterial pressure. Peripheral resistance is regulated primarily through constriction and dilation of arterioles. Cardiac output is regulated by the mechanism discussed previously. The regulation of arterial pressure through processes that alter peripheral resistance and cardiac output is discussed later on in the day. So, your overview of control systems. Under normal circumstances, arterial pressure is regulated primarily by three systems: the ANS, the Renin-Angiotensin-Aldosterone system, and the kidneys. These systems differ greatly with regard to time frame of response. The ANS acts in two ways. It responds rapidly, in seconds or minutes, to acute changes in blood pressure, and it provides a steady state control. The RAAS, or Renin-Angiotensin-Aldosterone system, responds more slowly, taking hours or even days to influence your arterial pressure. The kidneys are responsible for long-term control and therefore may take days to weeks to adjust that arterial pressure. Arterial pressure is also regulated by a fourth system, a family of natriuretic peptide. These peptides come into play primarily under the conditions of volume overload. A steady state control by the autonomic nervous system. Again, the ANS regulates your arterial pressure by adjusting your cardiac output and peripheral resistance. Sympathetic tone to the heart increases the heart rate and contractility, thereby increasing your cardiac output. In contrast, your parasympathetic tone slows the heart and thereby reduces cardiac output. As discussed in Chapter 13, constriction of blood vessels is regulated exclusively by the sympathetic branch of the ANS. Blood vessels have no parasympathetic innervation. A steady state sympathetic tone provides a moderate level of vasoconstriction. The resultant resistance to blood flow maintains arterial pressure. Complete elimination of sympathetic tone would cause arterial pressure to fall by up to 50%. So, rapid control by the autonomic nervous system, the baroreceptor reflex. The baroreceptor reflex serves to maintain arterial pressure at a predetermined level. When your arterial pressure changes, the reflex immediately attempts to restore arterial pressure to the preset value. The reflex works as follows. Baroreceptors, or pressure sensors in the aortic arch and carotid sinus, sense arterial pressure and relay this information to the vasoconstrictor center of the medulla. When arterial pressure changes, the vasoconstrictor center compensates by sending appropriate instructions to arterioles, veins, and the heart. So, an example, when arterial pressure drops, the vasoconstrictor center causes constriction of nearly all arterioles, thereby increasing peripheral resistance. constriction of the veins, thereby increasing venous return, and an acceleration of the heart rate. And that is done by increasing the sympathetic impulses to the heart and decreasing parasympathetic impulses. This combination effect of these responses is to restore your arterial pressure to the preset level. When your arterial pressure rises too high, the opposite responses occur. The reflex dilates arterioles and veins and slows the heart rate. The baroreceptor reflex is poised for rapid action, but not for sustained action. When your arterial pressure falls or rises, the reflex acts within seconds to restore the preset pressure. However, when your arterial pressure remains elevated or lowered, the systemic resets to the new pressure within 1 to 2 days. After this, the system perceives the new elevated or reduced pressure as normal and ceases to respond. Drugs that lower arterial pressure will trigger the baroreceptor reflex. So, for example, if the administration of a drug that dilates arterioles, the resultant drop in peripheral resistance will reduce arterial pressure, causing the baroreceptor reflex to activate. The most noticeable response is the reflex tachycardia. The baroreceptor reflex can temporarily negate efforts to lower arterial pressure with drugs. So, speaking on the renin-angiotensin-aldosterone system, or RAAS, which helps support arterial pressure by causing constriction of arterioles and veins, and by the retention of water by the kidneys. Vasoconstriction is mediated by a hormone named angiotensin II. Water retention is mediated by aldosterone through the retention of sodium. Responses develop in hours, the vasoconstriction to days via water retention. The renin-angiotensin-aldosterone system and its role in controlling blood pressure are discussed in Chapter 36. The renal retention of water. When arterial pressure remains low for a long time, the kidneys respond by retaining water, by which in turn causes arterial pressure to rise. Pressure rises because the fluid retention increases blood volume, which increases venous pressure, which increases venous return, which increases cardiac output, which therefore increases arterial pressure. Water retention is a mechanism for maintaining arterial pressure over long periods, weeks, months, even years. The reduction of arterial pressure causes the kidneys to retain water because low arterial pressure reduces renal blood flow, which in turn reduces glomerular filtration rate. Because less fluid is filtered, less urine is produced, and therefore more water is retained. A low arterial pressure activates that renin-angiotensin-aldosterone system, causing levels of angiotensin II and aldosterone to rise. Angiotensin II causes constriction of renal blood vessels and thereby further decreases your renal blood flow, or RBF, and GFR, the glomerular filtration rate. Aldosterone promotes renal retention of sodium, which causes water to be retained along with it. Which brings us to postural hypotension. Postural hypotension, also known as orthostatic hypotension, is a reduction in arterial pressure that can occur when we move from a spine or seated position to an upright position. The cause of hypotension is pooling of blood in veins, which decreases venous return, which in turn decreases cardiac output. Between 300 and 800 ml of blood can pool in veins when we stand, causing a cardiac output to drop by as much as 2 liters per minute. When we stand, gravity increases the pressure that blood exerts on veins. Because veins are not very muscular, they are unable to retain their shape when pressure changes and increases, and therefore they stretch. The resultant increase in venous volume allows blood to pool. Two mechanisms help overcome postural hypotension. One is the system of auxiliary venous pumps, which promote the venous return. In fact, in healthy individuals, these auxiliary pumps usually prevent postural hypotension from occurring in the first place. When postural hypotension does occur, the baroreceptor reflex can restore arterial pressure by constricting veins and arterioles and by increasing the heart rate. What would happen if we gave a drug that promotes the dilation of veins or prevented them from constricting? Well, in patients taking drugs that interfere with venoconstriction, postural hypertension is more intense and more prolonged. Hypotension is more intense because the venous pooling is becoming increased and greater. Hypotension is more prolonged because there is no venoconstriction to help reverse that venous pooling. As the drug that reduces arterial pressure by dilating arterioles, drugs that reduce arterial pressure by relaxing veins can trigger that baroreceptor reflex and can therefore cause reflex tachycardia. Which brings us to the natriuretic peptides. Natriuretic peptides serve to protect the cardiovascular system in the event of volume overload, a condition that increases your preload and thereby increases cardiac output and arterial pressure. Volume overload is caused by excessive retention of sodium and water. Your natriuretic peptide works primarily by reducing blood volume and promoting the dilation of arterioles and veins, which both actions could lower your arterial pressure. The family of natriuretic peptides has three principal members: atrial natriuretic peptides, or ANP, or a brain natriuretic peptide, or BNP, and finally the C natriuretic peptide, CNP. ANP is produced by the myocytes in the atria. BNP is produced by the myocytes of the ventricles, and to the lesser extent by the cells in the brain, where BNP is discovered. And lastly, the CNP, which is produced by the cells of the vascular endothelium. When blood volume is excessive, all three peptides are released. The release of ANP and BNP is triggered by stretching of the atria and ventricles, which occurs because of an increase in your preload. Your ANP and BNP have similar actions. Both peptides reduce blood volume and increase venous capacitance and thereby reduces cardiac preload. Three processes are involved, the first being ANP and BNP shift fluid from the vascular system to the extravascular compartment. The underlying mechanism is increased vascular permeability. The second, these peptides act on the kidney to cause diuresis, or the loss of water, and natriuresis, the loss of sodium. The third, they promote dilation of the arterioles and veins, in part by suppressing sympathetic outflow from the central nervous system. In addition to these actions, ANP and BNP help protect the heart during the early phase of heart failure by suppressing both the RAAS, that Renin-Angiotensin-Aldosterone system, and the sympathetic outflow, and by inhibiting proliferation of myocytes. Although CNP shares some of these actions of ANP and BNP, its primary action is to promote vasodilation. And that completes our chapter here. So we'll see you all at the next chapter.